there's some data that came out of the second part first. There's some data that has come out of the French group that looks impressive to say that bispecifics in patients post CAR T seem to be the best option as far as salvage. So I do think, based on that and the MCO data and what we saw with large cell lymphoma, that there will be a role for the bispecifics post CAR T, as long as these the disease still expresses CD20. Now, if we go into basically T-cell naive patient population, there will be obviously some discussion, and we'll need longer follow-up whether there needs to be sort of a role one before the other. But unlike what we see in large cell lymphoma, unfortunately, CAR T isn't curative in mantle cell lymphoma. And so in that situation, it does raise the question of whether you can introduce the bispecifics, especially with the data more recently that came out of ICML with the mosunetuzumab and polatuzumab, whether this may be a more feasible option for some patients versus going to CAR T-cell therapy, especially if we look at community settings, which obviously don't have access to CAR T, and patients, at least in the US, that may not be willing to come to CAR T-cell centers to receive these medications. So I think over the next couple of years, there will be a lot of jockeying back and forth, and maybe there doesn't have to be a complete sequence, and maybe we just make adjustments based on our patient's preferences and where we're located to determine which of these agents we give first or second. But I do think, at least from what we have right now, giving one before the other does not preclude us from giving the other one at relapse, and allows us to hopefully allow for more durability of response for these patients, given that we can sequence these two T-cell therapies irrespective of which one goes first.